I'm Dr. Venkatesh Ramaiah. The Chief Vascular Surgeon at the Scottsdale Honor Network. I'm also the Chief of Complex Vascular Services in the HonorHealth Network in Scottsdale, Arizona. I'd like to present an ALTO case review. ALTO is the endograft that's a little different from the other current available endografts on the market. To give you a brief description of this particular endograft, it has polymer technology, which allows for less neck dilatation compared to the other endovascular stent grafts available on the market. It does have suprarenal fixation, and it does have nice tortuous extensions, which allow us to get good seal in the distal iliac vessels, period. To highlight these features, I'd like to present a case. So this is an 86-year-old female patient who came in actually into the hospital for a hip replacement, and on routine workup, it was found that she had a 6-centimeter, pretty large abdominal aortic aneurysm. She presented with some vague abdominal pain and back pain, and workup revealed this large 6-centimeter abdominal aortic aneurysm. Let's look at this aneurysm. As you can see, it's large. It's 6 centimeters in diameter, which is pretty large for a female patient. But interestingly, you will see that it has a very tortuous anatomy. The neck is almost, as you can see at the top of the screen, not only short, but also severely angulated. And she has severely angulated iliac vessels or access vessels, period. She meets the criteria because she is extremely high risk of an endograft. Obviously, she is not really a candidate for a big open operation. She has severe comorbid conditions, as mentioned. And so we evaluated her for an endograft treatment of her abdominal aortic aneurysm. Now, of all the currently available devices on the market, we chose ALTO. One, because it is the lowest profile device on the market. Two, it is approved for a relatively short neck of 7 millimeters within the IFUs. And based on the angulation too, it fits within the IFUs of the ALTO stent graft that's available on the market right now. The reason we chose ALTO is also because not only of its profile, but also of its ability to conform to the morphology and the anatomy of these tortuous aneurysms, period. You should do all endograft or endoluminal stent grafting of abdominal aortic aneurysms within the IFUs of that particular device. And I think this fits in very nicely with the ALTO device. You can see the infra-renal neck angulation. You can see the size of the aneurysm. You can see the measurements of the diameter of the proximal neck, and also the iliac limbs that we will use to get distal seal. We have selected a 23 millimeter ALTO graft that will seat right at the level of the lowest renal artery. And then we have the limb extensions into the iliac vessels. So here is the preoperative angiogram. I won't go into all of the details, but again, as you can see in this preoperative angiogram on the left side, you will see the neck angulation. You will see the takeoff of the left renal artery and the takeoff of the right renal artery. The neck itself is actually fairly long, but extremely tortuous, as we mentioned earlier. And you can see also that the iliac vessels are severely tortuous. So when we do this procedure, we put in a stiff wire, a Lundquist wire. We then deploy the main body, which is the ALTO device. And this is done very sequentially. And if you see the deployment steps of the ALTO graft, you can literally land the graft right at the level of the lowest renal artery. And as the sealing rings and as the rings expand with polymer, we were able to see, if you take the stiff wire out, we will be able to see how the graft literally conforms to the angulation of the neck of the aneurysm. And you can see extreme right, you can see how the sealing zone, we've occupied almost the entire length of the neck of the aneurysm to get complete seal as well as fixation with the suprarenal elements too. So ALTO has a really good adaptive sealing zone, and a really good suprarenal fixation, which is very key for fixation and seal so that the graft does not migrate in the future as the aneurysm confirms or shrinks accordingly and changes its morphology. So once we get the neck completely sealed, we can see that this is the most important portion of the fixation of the aneurysm. The distal seal zones, then we extend with iliac ovation limbs, and we do it under road mapping guidance. So we go right to the level of the external internal junction, and we use these limbs accordingly, period. So as you can see, we've got complete seal of the aneurysm. If you compare the left-hand picture to the right hand, you will see that the aneurysm sac does not distend once the dye is in there. So we got good seal and good fixation in this particular case. So again, if you look at the picture on the left-hand side, at 30-day follow-up, you'll see the sealing rings are right at the level of the lowest renal artery. They're completely adapted or adopted to the morphology of the neck of the aneurysm. And you can see the tortuosity of this and how the graft has sort of molded itself to this morphology. You'll see the sealing rings still have contrast in them because as the polymer expands, you can actually see this polymer and this will dissipate over a period of time. And then you can see that the neck of the aneurysm is completely sealed. You can see that there is no dye in the entire aneurysm sac. All of the contrast is well within the limbs of the endograft, and there is absolutely no endoleak, whether it be type 1, type 2, or other kinds of endoleaks. And the aneurysm actually, even in 30 days, has actually shrunk a little bit from 6 centimeters to 5.7 centimeters. And then finally, on the right-hand side, you get this nice colorful picture of the endograft with the limbs that are crossed and complete seal of the aneurysm, showing not only the left renal, which is on the downward angle, but also the sealing rings, which have really sealed the aneurysm right at the level of the left lowest renal artery. So this is an example of a fairly complex case using the ALTO endograft, which basically allows for treatment of patients who have severe iliac disease because of its low profile, and allows to seal these aneurysms with a technology that utilizes polymer that prevents neck expansion and eventually migration of the endografts. It has good adaptive seal because of the polymer, and it has good proximal fixation, not only with the suprarenal rings, but also with the mid cage, which allows us to deploy the endograft right at the level at the lowest renal arteries. And that is why this particular graft is now approved for 7 millimeter necks, as indicated in this particular case.